Welcome everyone to our oxygen therapy and critical care case-based series. We're on session 7, defining ARDS. Today we have a fantastic panel for you. We have Dr. Anna Maria Crawford from Stanford University, Dr. Nicholas Suarez, American British Cowdrey Medical Center, Dr. Jackson Kwizera, Kibogora District Hospital, Rwanda, Dr. Theogene, University of Rwanda, Dr. Vanessa Mole, University of Zurich, Dr. Balavenkat Subramanian, Ganga Medical Center and Hospitals, India, and Dr. Eric McDaniel, University of Minnesota. We'll just go through, as always, a little bit of housekeeping before we begin. Our Project ECHO programming is based on a foundation of love and respect. Please respond kindly rather than react if you disagree with something. We will be using the chat function for questions and answers. So at the bottom middle of your screen, you'll see a chat box. Please send all questions through the chat box and feel free to introduce yourself. Please turn on your video if you can. Position your webcam to show your face, or if alone, or to capture the whole group. If you have any IT issues, please send a message through the chat to ECHO IT and we'd be happy to assist you. This session is being recorded and your attendance is consent to be recorded. And we'd just like to mention that please be mindful of infection prevention and control. Try to limit numbers of people joining from one gathering place and practice physical distancing. So we have interpretation today in French and Spanish. You will need a new version of Zoom for this to work, but choose to mute. You can choose to mute the English part of the session or listen to both. Translation will be louder than the speaker. You can see there's an interpretation button on the bottom of your screen, and you can choose Spanish or French. And with that, I will pass it along to Dr. Crawford.
Hello, everyone. Welcome. It's good to see you again. We have an amazing group of panelists from literally all over the world, from Latin America to Africa to Europe to North America. So we're very excited to have this group of experts with us today. All the materials that we will discuss today can be found on the Global Anesthesia and Critical Care Learning Resource Center. So you can see that site here. I will also put it in the chat box, if someone can help me with that. Actually, here, I've got it. Okay. So once you go to the Learning Resource Center, we're going to be within the Oxygen Series course. And once you select that, you're going to go into the Oxygen and Critical Care Case-Based Discussion Series. And again, as mentioned, we're going to part 7. We're going to talk today about defining ARDS. So once you click on that, you'll be asked to sign in. It's free to make an account. Anyone can have a free account to this Learning Resource Center, and you're welcome to share this Learning Resource Center with anyone. So last time we talked about a patient, Mr. T, who is a 46-year-old man who presented with hypoxemia and respiratory distress. Today, we're going to continue the case with Mr. T, and we're going to talk about defining ARDS. Instead of having learning objectives, we like to have practice change objectives, because to really impact patient outcomes, we need to not only have the knowledge and skill set, but we need to act upon it and make the best decisions for our patients. So our first practice change objective is to define respiratory failure. Then we want to list the types of respiratory failure. We want to define hypoxemia, and this can be defined using a pulse oximeter or an arterial blood gas analysis. So we'll talk about the definitions of hypoxemia using both of those modalities. We want to list the 4 key criteria for the definition of ARDS, and we want to know how to apply the Kigali modification to diagnose ARDS. Then we want to know whether the ARDS is considered mild, moderate, or severe. And we want to describe the pathophysiology that occurs in ARDS, that we can better understand how our treatment interventions will act to improve the patient's outcomes. We want to talk about the lung protective ventilation strategies. We want to understand which parameters on mechanical ventilation or mechanical ventilators are adjusted for oxygen versus carbon dioxide elimination. And then we want to apply the interventions that are known to improve oxygenation and also apply the interventions that are known to improve outcomes in ARDS patients. Okay, so let's continue on with our case with Mr. T, a 46-year-old man who presented with hypoxemia and respiratory distress. Unfortunately, Mr. T was found to be positive for SARS-CoV-2 virus or COVID-19 disease, and his clinical course progressed to respiratory failure. He required admission to the intensive care unit, intubation, and mechanical ventilation. His vital signs and mechanical ventilator settings are as follows. His heart rate is 102 beats per minute. His blood pressure is 97/51 millimeters of mercury. His respiratory rate is 35 breaths per minute. His temperature is 37.5 degrees Celsius, and his SpO2 or pulse oximeter reading is 90%. On the mechanical ventilator, he's on assist control using a volume control settings. He has an FiO2 requirement of 100%. Again, his respiratory rate is 35. His tidal volume is 400. His PEEP is 14, and his peak inspiratory pressure is 40. So the first thing we're going to talk about, the first topic that we outlined in our practice change objectives, is respiratory physiology and failure. And first I want to ask the audience, have everyone take a big deep breath. Do it again. Good. I see you guys are doing it, which is great. So I want to know, why do we breathe? You can answer in the chat box, but I'm going to click on the reference. So when you're in the Learning Resource Center, when you see a question box, you can see click, you can try to click on it and you may be taken to an additional resource or article or video. So this one takes us to a reminder about cellular respiration. This one does take just a second to load, but we breathe to bring oxygen into our lungs and to get carbon dioxide out of our bodies. And so why do we need that extra oxygen? And the answer is cellular respiration. This may take just a second, apologies. Does anyone remember why oxygen is needed? So oxygen is needed inside of the mitochondria, and it's the final acceptor of the electron transfer, which produces the most ATP in cellular respiration. So oxygen is needed for aerobic metabolism in every single cell in our bodies. As part of cellular metabolism, carbon dioxide and water are waste products. So we need oxygen to come into every single cell in our body, and we need to get rid of the carbon dioxide as a waste product. So this is just a reminder about cellular respiration. This is why we breathe. So how do we breathe? What happens in our lungs? This video is only 30 seconds long, so let's see what this video shows us.
When you breathe in, air enters your nose or mouth and passes into your trachea or windpipe. At the carina, the trachea divides into two bronchi, then branches into smaller bronchioles. The bronchioles end in tiny air sacs, or alveoli. Here, the oxygen in the air you inhale passes into the bloodstream, and carbon dioxide from your body passes out of the bloodstream. The carbon dioxide is expelled from your body when you exhale.
Okay, great. So that is a very basic reminder. Again, that's respiratory physiology. So next we're going to talk about respiratory failure. So we know we need to bring oxygen in for cellular respiration and get rid of carbon dioxide as a waste product. Everybody take another big deep breath. Great. Is Dr. McDaniel here? Is he signed in yet? He might not be here quite yet. I know he was getting off work late. So the first question is going to be, which one of the following statements about respiratory failure is incorrect? And I think this might be a poll question, so we can launch this as a poll so the audience can answer. So which of the following statements about respiratory failure is incorrect? Respiratory failure is a failure of gas exchange, either oxygenation or carbon dioxide elimination. Respiratory failure can be acute or chronic. Respiratory failure is a syndrome rather than a disease. Respiratory failure usually resolves on its own. Patients in respiratory failure have tachypnea, hypoxemia, and hypercapnia. And I can see the audience is already answering, which is wonderful. So we'll give you just about 30 seconds more to answer this question before we start the discussion. Okay, great. I can see that 73% of people answered D, which is the incorrect phrase, but the correct answer. So that's very good. So respiratory failure is defined as a failure of gas exchange. You're either not getting enough oxygen in, or you're not getting rid of enough carbon dioxide. It is acute or chronic. You can have chronic respiratory failure and you can have acute respiratory failure. It is a syndrome rather than a disease. So respiratory failure is a symptom or a syndrome of something else happening within the body. It does not usually resolve on its own. Usually patients in respiratory failure need your help. They need your intervention to support their breathing. And symptoms that are common with respiratory failure include tachypnea or fast breathing, hypoxemia, low oxygen, or hypercapnia, high CO2. So the next thing we're going to do is describe the types of respiratory failure. So there are 4 different types of respiratory failure, and I'm going to give you about 30 seconds to type into the chat box the types of respiratory failure. So I'll let you guys have 30 seconds. 1, 2, 3, 4, and then we'll give you the answer. Okay, stop. That 30 seconds is up. And because I'm screen sharing, I cannot see the chat box. So I'm going to ask one of my co-panelists if they don't mind reading some of the answers in the chat box about the types of respiratory failure. Were there any good answers? Maybe Dr. Moll can help me, or Dr. Bala?
Yeah, there was an answer which said type 1 and type 2 respiratory failure. Mm-hmm. There was another one which said acute, then chronic, and acute on chronic.
Yeah. Okay.
And another one said hypoxemic respiratory failure and hypercapnic respiratory failure.
Beautiful. So those are partially correct. I would say correct. But let's click on this box. You see when you're on the Learning Resource Center, you can click on the box to get taken to an article, a video, some sort of reference. And so what we're going to talk about are the classification of respiratory failure. Type 1 is also known as hypoxemic respiratory failure. And so they say a PaO2 less than 50 millimeters of mercury on room air. Type 2 is hypercapnic ventilatory respiratory failure, and that's a retention of CO2 or a lack of elimination of CO2. Type 3 and type 4 are less discussed. I have to admit, I talk about type 1 and type 2 all the time in the intensive care unit, but I very rarely talk about type 3 and type 4. But you can know that there are two other types of respiratory failure. Type 3 is perioperative respiratory failure. So these are generally patients who have undergone an anesthetic and a surgery, and so they have respiratory failure thereafter. And then type 4 is secondary to cardiovascular instability or shock. So there are 4 types of respiratory failure: type 1, type 2, type 3, type 4, hypoxemic, hypercapnic, perioperative, and shock. So those are the types of respiratory failure. What type of respiratory failure does Mr. T have? Very good. Someone says type 1. Anybody else? Only one person wants to answer this. Oh, there's another one. Great. Yeah. So Mr. T has type 1. He may have type 2. We don't know because we haven't revealed an arterial blood gas analysis. And so type 2 is hypercapnic. So he definitely has type 1 because we see he's hypoxemic on his pulse oximetry. Okay, let's move on. We're going to talk about the definitions of hypoxemia. If you recall, as a practice change objective, we're going to know how to diagnose hypoxemia both with pulse oximetry and with an arterial blood gas analysis. So here we have a case update. The bedside ICU nurse calls you and says, Mr. T's saturation has dropped to 88%, and you can see the pulse oximeter reading here. And so we're going to talk about hypoxemia, and I'm going to ask my dear colleague, Dr. Bala, to help us talk how is hypoxemia defined using pulse oximetry, and how is hypoxemia defined using arterial blood gas analysis.
So maybe should we put the question first to them, asking how do you define hypoxemia with pulse oximetry? We'll get 30 seconds for the participants to respond.
Perfect. And I'll set a timer for us.
Yeah.
So we are way past time. So we have a couple of answers in the chat box, Dr. Bala.
Yeah, the few of them have said a saturation of less than 90, and some said the PaO2 of less than 50. So when we speak about pulse oximeter, I think we are speaking about the saturation of the oxygen. It is different from the arterial blood gas analysis. So I think that I wanted to make it very clear. So a pulse oximeter is the one which finds out the percentage of saturation of hemoglobin with oxygen. It's different. We are going to go to that later. Now, shall we see the reference from the Learning Center? So, so what I would just wanted all of you to know is whenever you see a saturation of less than 90% on the pulse oximeter, it's very important that if you are the healthcare worker assisting in this patient, you need to start immediately on oxygen. It could be through the nasal cannula, a nasal catheter, or a face mask. This is one of the ways that you would start oxygen. And if it's less than 5 years, We recommend less than 5 years in a small child. It's best to use nasal prongs, which is well accepted by the patient. Keep simple surgical face mask on patient over nasal prongs because it's COVID time and you don't want the healthcare workers to get infected. So I would wanted to emphasize this point that do keep a 3-ply surgical face mask over the nasal prongs on the mask to prevent the cross-contamination. So what you do next? So you need to target oxygen saturation of more than 90, and you will adjust your flow based on that, the oxygen flow that you set in. You will adjust the flow rate based upon the saturation. And it's best to get a saturation, a target of more than 94. And if it's a pregnant patient, the target should be anywhere between 92 to 95%. But if the target saturation is more than 90 cannot be achieved, then you really suspect acute respiratory distress syndrome, which means just supplying oxygen to the patient is not sufficient to enhance the ventilation perfusion, and we are not able to increase the oxygen content of the blood. So this is the time that we consider putting this patient on prone positioning, which has proved to do a lot of good to your patients, especially in the COVID virus situation. So the minute you put the patient on prone, many times we see the oxygen saturation going more than 90, and this will aid us in getting the patient out just through spontaneous and not requiring to go for mechanical ventilation. But after you put the patient in prone position, if still your oxygen level, the SpO2, if it does not improve, then it's the time that you need to go for advanced oxygen therapy and mechanical ventilation is required. So if we need to do this, he needs to be moved from the normal ward to an intensive care or the critical care unit where the patient would need an intubation and an endotracheal intubation and mechanical ventilation started with oxygenation. So these measures are really vital, and it's very important that each one of us are aware of the stepwise upgrading your oxygen supply to the patient based upon the following parameters in the pulse oximeter.
Dr. Bala, that's wonderful. Thank you so much. I'm going to ask the same question throughout the entire session because many of our participants are practicing with resource constraints. Can this be done if you practice in a setting that does not have an intensive care unit or if you don't have a mechanical ventilator? Which of these can be done? Which of these interventions can be done? And this is a question I know Dr. Bala knows the answer, but this is a question for all of the learners as well. So which of these things can be done even if you don't have an intensive care unit? I would argue if you have access to oxygen, you can use oxygen. What else?
There's an answer saying proning is possible in every place.
Yeah, you can prone anywhere. So even if you practice in a setting that does not have an intensive care unit or intensive care specialists or mechanical ventilators, you can give your patient oxygen and prone them. And I think this is a really important point because we're talking about practice change objectives, not just learning what should be done. We need to know how we can actually take action, isn't it?
Yeah, so there's another one which says that use nasal cannula with a non-rebreathing system to give about 20 liters per minute. High flow oxygen, probably they mean it.
Mm-hmm. So I think that is something we've talked about in previous sessions, Dr. Bala, is the appropriate selection of oxygen flow for each device. And it's really important that our learners understand which devices require which levels of flow Similarly, which patients can tolerate certain levels of flow, because in very small infants, for example, high flows can actually be dangerous. So it's important for everyone to recognize the flow limitations of the oxygen delivery devices they have chosen. Wonderful. Thank you, Dr. Bala.
Yeah. So probably we move on to the next question.
Yes, please.
So if you are in a setting where you have the ability to do arterial blood gas analysis, then how will you go about defining hypoxemia? And this is for a question for 30 seconds. We would want all of you to respond.
I'll set the timer again, Dr. Bala. Okay, that has been over 30 seconds.
Yeah. So I see a lot of them in the chat box too. So probably we'll go to the reference. So it's a long list of references. I would wanted all of you to go to the Learning Resource Center to go through this. But in general, I just would wanted you to give a lot of focus on the PaO2. A PaO2 of between 75 to 100 is called normoxemia or normal oxygen level. Anything less than 75 is indicative of hypoxemia. And when you go less than 50, it becomes severe hypoxemia. So the arterial blood gas analysis is one which helps us to see the level of PaO2. It also assists us to know the pH of the patient and the PaCO2. These, along with the oxygen level, helps us to identify whether the patient is acidotic, and if he is acidotic, whether it's metabolic or respiratory. Just one word about it. If the PaO2 is low and the PaCO2 is high, the PaCO2 high produces the respiratory acidosis. And if the PaO2 is low and the tissue perfusion is less, more of acid is produced in the body and it produces metabolic acidosis. So these three parameters really help us to know the normoxemia, the metabolic and the respiratory acidosis.
Perfect. Dr. Bala, thank you so much for walking us through hypoxemia with pulse oximetry and arterial blood gas analysis.
Thanks,
Thank you
Anna.
So we'll move on to our next topic, which is how we define ARDS. And we have another poll question for the audience. I'm going to ask Dr. Jackson to help us with defining ARDS. Dr. Jackson, oh, you're here with us. Thank you so much. You can unmute. Perfect.
Yeah, I have already unmuted. Hi, team. I think we can first see the answers from the audience, and then we shall talk after seeing their answers.
Yeah, that's perfect.
Is that okay?
We can launch a poll question through the Zoom. Yeah, we can launch a poll question.
So our first question was to what does ARDS stands for? And I think it's now 30 seconds, and I think most of the respondents got it well with acute respiratory distress syndrome. So we are heading to the 4 components. I think they got it well with acute respiratory distress syndrome, and let's go to the components.
Jackson, if I may, before we move on, 83%
Okay.
answered acute respiratory distress syndrome, but 17% actually responded adult respiratory distress syndrome. And although that answer is not correct today, it was correct in history. So ARDS was first described in the 1960s by military clinicians, and they also called it shock lung. So this was a description that came out very long ago. And then the civilian clinicians decided that to call it adult respiratory distress syndrome to distinguish it from pediatric patients. However, they realized that ARDS can occur in any patient, so the name was changed from adult to acute. So although if you answer adult respiratory distress syndrome, you're not entirely wrong, but you're just stuck in some history.
Thank you, Anna. This is a very good comment to this particular component. And you took us back to the history, which is very good. We can go now to the components of ARDS, and looking forward to see the answers from the respondents.
So everyone can type in the chat box, list 4 components outlined in the Berlin definition of ARDS.
That's true. You can already see me.
So we have some great answers in the chat box.
Yeah, I can see we have some great answers, even though people were just not listing all the things. A few of them listed all the 4 components. I can see as we go through the Berlin definition criteria with all the 4 components, we have acute onset within 1 week of an insult, new or worsening conditions within 1 week, and then we may have bilateral infiltrates, which are found with chest X-ray or radiography, or even CT scan. And then you have features of pulmonary edema which are not fully explained with by cardiogenic edema or fluid overload. And then the 4th criteria will be defined by the severity, which is a ratio of partial pressure of oxygen of an FiO2 that you are giving to the patient. And then this ratio should be on at least 5 centimeters of mercury of positive pressure ventilation, or a PEEP in case you have non-invasive ventilated patients on CPAP. In advanced or specialized settings, you'll be having all these characteristics, and then you define this ARDS. I don't know if Anna has any more clarification on this, but basically you have the acute onset of the symptoms within 1 week of a new or worsening condition, bilateral infiltrate on chest radiography or CT scan, and then this pulmonary edema, which is not really fully explained by cardiogenic origin or fluid overload, and then the severity, which is mostly defined by the PFI ratio on ventilation settings of at least 5 centimeters of water on PEEP or positive pressure ventilation in case you have a PEEP or CPAP. I don't know if Anna has more clarification on this, but mostly you have this PFI ratio less than 300. This will be defining that you have a mild ARDS symptoms between 200 and 300 of that ratio, and then when it is between 100 and 200, this is a moderate symptoms, and then it would be severe when this ratio is less than 100. Anna, do you have more clarification there?
I think you did a great job pointing out the 4 components. So this is the clinical diagnosis according to the Berlin definition. But if you remember, we asked you to write 4 things on a line. So if you had to pick out one word for each one of those 4 components, I would say acute onset, bilateral. The third thing would be pulmonary edema that's not cardiac in origin. And then the 4th thing would be hypoxemia. And the hypoxemia is what we use to describe the severity of ARDS.
Yeah, sure.
I also want to, this reference is from Up to Date. You can see here. Up to Date usually requires a subscription, so you have to pay a fee to use Up to Date, which we all think is very unfortunate. We think education should be free. However, Up to Date is allowing information that could be related to the COVID-19 pandemic to be accessed for free. So you can still access Up to Date, and you may be able to get some information to help you care for your patients. If you are from a low or middle income country, you may actually qualify for a free Up to Date subscription. Up to Date is very, very useful, and they offer some free subscriptions. So you can go to the Learning Resource Center and click here and see if you or your institution will qualify for that. So good. So Dr. Jackson, I think we can move on to the next question, which says to calculate the P to F ratio.
Sure. Let's see from the participants how to calculate the PFI ratio.
So the P is PaO2, which you get from an arterial blood gas. And the F is the FiO2, or the fraction of inspired oxygen concentration.
Yeah, sure.
And this P to F ratio to determine the severity of hypoxemia for ARDS, whether it's mild, moderate, or severe disease. So let's see if the audience can calculate the P to F ratio. The PaO2 is 60 and the FiO2 is 80%. Do you want to give them 30 seconds, Dr. Jackson?
Yeah, sure. We allow them 30 seconds, and then we shall calculate Mr. T's PFI ratio.
Perfect. Okay, 30
I
seconds.
can see most of the respondents got it well. The partial pressure of oxygen was 60, and then FiO2 fraction of oxygen, inspired oxygen of 0.8, which means they got 75. They got it well. And then from the respondent, we can get now to tell it is severe, mild, or moderate.
So I think it's a good learning point, Dr. Jackson, when you're calculating the P to F ratio. So you have the partial pressure of oxygen is 60, which we gave you.
Yeah, sure.
FiO2 is 80%. When you're doing this calculation, you actually need to use the oxygen as a decimal point.
Yeah, sure.
So it's actually 60 divided by 0.8, and that's how you get to the number 75. So we gave you, Dr. Jackson gave you the definitions of mild, moderate, and severe ARDS. So if his P to F ratio is 75, does Mr. T have mild, moderate, or severe ARDS? We have one person who comes in to say severe, which is...
Yeah, I can see. I can see most of the team are responding severe, which is true with our definition from the Berlin definition. And Mr. T's PFI ratio was describing the severe features of ARDS.
Perfect, wonderful. Dr. Jackson, thank you so much for your explanation about the 4 components of the Berlin definition of ARDS, which is acute onset, bilateral infiltrates, pulmonary edema not explained by cardiogenic factors, and then the 4th one is hypoxemia. Hypoxemia with a P to F ratio less than 300 is mild, less than 200 is moderate, less than 100 is severe. So unfortunately, our patient, Mr. T, has what we would consider severe ARDS. So the next question is for Dr. Teo. Dr. Jackson, thank you again. Dr. Teo, what if you don't have an arterial blood gas analysis available to you? Can you diagnose ARDS when there's no ABG? I think Dr. Teo should be with us. Hopefully he's unmuted. Does anyone see Dr. Teo? It's okay. We are very lucky to have Dr. Teo as our colleague and our friend, because I'm going to click on the reference for the answer. As you can see here, Dr. Teo is one of the authors of this wonderful paper that tells us how to estimate and how to diagnose ARDS, even if you don't have arterial blood gas analysis. So we'll click on this figure here and see if we can find the answer ourselves, even though we don't, Dr. Teo. So we mentioned the 4 components of the Berlin definition, which is the timing within 1 week. So it's an acute onset. When you use the Kigali modification is how to diagnose ARDS, even if you don't have arterial blood gas analysis. So for timing, it's the same, acute onset. So there's no modification to the definition. We talk about oxygenation, the PaO2 to FiO2 ratio. This is where you require arterial blood gas analysis. The Kigali modification says you can actually use the SpO2 or your pulse oximetry. And if your SpO2 to FiO2 ratio is less than 315, then you can diagnose the hypoxemia necessary for the defining ARDS. Another modification of the Berlin definition is the amount of PEEP. When we calculate the P to F ratio, we must be on at least 5 centimeters of water of PEEP or CPAP in order to use that calculation. That's with the Berlin criteria. With the Kigali modification, no PEEP is necessary. You can just use SpO2 to FiO2, less than 315. In chest imaging, remember we said that ARDS is bilateral. It's on both sides, affects both lungs. Those opacities are seen either with CT scan or chest X-ray. And what the Kigali modification says is that you can look at the lungs using either chest radiograph or ultrasound. So ultrasound, as most of you know, is becoming much more popular in diagnosing lung pathology. So you can use a CT or a chest X-ray or ultrasound. You don't have to have a CT scan. And then the origin of edema, remember there is pulmonary edema, but it's not from cardiac failure. And that has no modification with the Kigali modification. So in summary, the timing is the same. And both the definitions contain bilateral edema. But that edema can be seen with ultrasound or chest X-ray in a resource-constrained area. And also you can use pulse oximetry instead of arterial blood gas analysis for diagnosing that. So the question, back to the question, can ARDS be diagnosed when arterial blood gases are not available? And the simple answer is yes, absolutely. You can use your pulse oximeter. And if your SpO2 to FiO2 ratio is less than 315, that would be considered hypoxemia consistent with, and the other criteria are met, that would be hypoxemia consistent with ARDS. Wonderful, we're making good time. I think we may actually not run over time today. The next topic we're talking about in our practice change objectives is the pathophysiology of ARDS. And for that, I'm going to ask Dr. Vanessa Moll from Switzerland to help us walk through the pathophysiologic changes that occur in ARDS. So,
sure. Thank you, Anna. So, hi, everybody. It's great to be here and with you. It has been a great session so far. So we will continue with a couple of questions for you. Please list the 3 pathophysiological changes that come to your mind when you think of ARDS. And are we giving 30 seconds time again, Anna?
Yes, that sounds great. I'll start a timer for us.
Okay, perfect. Thank you.
So I will say we asked for 3 changes, but there are many changes that occur in ARDS, isn't there?
There's 3 phases in ARDS that we shall discuss later, but many changes, yes.
Okay, so 30 seconds is up, Dr. Moll.
All right. Well, we have some good answers, like pulmonary edema and decreased surfactant production. That's fantastic. And so the ARDS can be divided into 3 different phases: earlier phases and later phases. So they are the exudative phase, the proliferative phase, and then lastly, the fibrotic phase, so the scarring phase. And each of these phases has different hallmarks, so to say. So we'll discuss first the acute phase, the exudative phase. And there are, yes, thank you. There is a fantastic image that we should look at, that Alana is pulling up right now, that shows us. Oh, Anna, you are doing that. Okay, great, thank you.
If something goes wrong with the images, it's Dr. Anna, not Alana.
Oh, no.
I don't want her to be blamed for my, okay, here we go.
Okay, thank you. And so here you see images of alveoli. And on the left upper hand corner, you see a very healthy, happy looking alveoli. So the ball is the alveoli, and below the ball you have a vessel. And so between the interface of the alveoli and the vessel, you will have the gas exchange. And you can see a couple of cells in the alveoli. There is the alveolar type 1 cells. Those are the flatter cells. Yes, and right next to the flatter cells are the alveolar type 2 cells. Yeah, exactly. And so in ARDS, in the exudative phase, you see on the right upper hand picture, you see fluid filling in the alveoli. And you can see how the membrane of your capillary below have holes. So you have a diffusion from the interstitium into the capillary and out of the capillary into the alveolus. And there's also a couple of spiky cells in there, and those are actually the cytokines and inflammatory mediators that are floating around in the alveoli. These cause damage to the endothelium and epithelium, also highlighted in red. The vascular and cellular permeability leads to more fluid influx. So the alveolus is basically drowning. The surfactant that usually keeps the alveolus, the balloon open and round is deactivated, leading to alveolar collapse. And then you also have microthrombi. So you can see in the capillary to the left, there is a little microthrombus. The second phase is the proliferative phase. Excuse me. And this phase is for repair and restoration. So the fluid goes back into your capillary, and the cells are being repaired, so you don't have this capillary leak anymore. The fluid is resorbed and goes into the lymphatic system. The epithelial cells proliferate again and heal. And now you have surfactant production again, and so your alveoli is going back to a nice voluminous form. And the permeability is reduced. So this is a healing alveoli. However, this healing can lead to scarring, and so you will have basically a fibrosis. So an alveolar fibrosis can occur and a thickening of the membranes. So you can imagine that the gas exchange through the alveoli and into the capillary is damaged and not that possible. So you have an alveolar scarring fibrosis and interstitial scarring, and due to the scarring in the capillary, you have a higher resistance in the capillary, which eventually can lead to pulmonary hypertension if a lot of capillaries are affected. Hopefully this will not happen and your patient will heal, but it does occur.
Wonderful. Thank you so much, Dr. Mull. That was an excellent review of the pathophysiology. So there's three phases, but within each phase, there's lots of pathophysiologic changes occurring. I think that this little video is a good demonstration of the exudative phase and how the distance between the alveolus and the capillary, that distance increases and gets filled with fluid and affects gas exchange. So when that happens, you get hypoxemia. So we'll watch this. It's not very long, but you can see that the inflammation starts and then fluid rushes in, and it really separates the alveolus from the capillary. And so that's why we have hypoxemia as part of the core definition of ARDS. So I want to introduce another useful resource for the learners, opencriticalcare.org. So this was launched in August, and it's a really great resource library. It has a lot of useful references, guidelines, tables, etc. So if you have a chance to look at opencriticalcare.org, they also go through some of the definitions of ARDS, treatments of ARDS, and a lot of the same things that we're talking about today. Wonderful. So the next section, Dr. Mull, I'm going to hold on to you if you don't mind to help me with the next session, which is treating ARDS. So when our patients have been diagnosed with ARDS, they need to be treated and supported through their disease. We talked a little bit already about oxygen therapy and proning. And if you have resources, we'll talk next about mechanical ventilation, remembering that one of our practice change objectives was understanding and utilizing lung protective ventilation. And I'm going to ask you again, just like I asked before, which of these things can be done even if you don't have an ICU, mechanical ventilators, and those types of resources. But first, we will talk about mechanical ventilators. So I'll let Dr. Mull once again take over this next question, which I believe might, oh no, I was going to say it was a poll question, but it's not. So Dr. Mull, lung protective ventilation.
Excellent, thank you, Anna. So in order to talk about lung protective ventilation, we need to first define a couple of terms. And lung protective ventilation is based on volume, the pressure, the oxygen, and all of that. Excuse me, we have the helicopters landing right now. And based on those three,
practice in a high resource setting.
Yeah, exactly. Based on the volume, the oxygen, and the pressures, you will define the lung protective ventilation. So what is the tidal volume? The tidal volume is the volume that you will give to your patient, that you set on the mechanical ventilator. Then you will set on the ventilator your FiO2, which is the fraction of inspired oxygen that we already talked about. You have a plateau pressure, and the plateau pressure actually reflects the pressure in your alveoli. So it's one of the very important pressures to know. So here, studies have shown that the plateau pressure should be less than 30 centimeters of water. If higher, it can be related to higher mortality. The next point is your driving pressure. This is a concept that is rather new. I think it originated in 2014 by a group from Brazil. And the driving pressure is your plateau pressure minus your PEEP. And it is an expression of the lung stress. So the lung stress is basically how your lung can expand. You're targeting less than 15 centimeters of water. And the paper has shown that you will have an increased mortality risk if your driving pressure is higher than 20.
And I think driving pressure, Dr. Mull, is really a symptom of compliance in the lungs, wouldn't you say?
Yes, yeah, that is very true. And
so if you require a high driving pressure, that means that your lungs are stiff and not very compliant, isn't it?
Exactly, very true, yes. And you can calculate the compliance by your tidal excuse me, by your tidal volume and basically your driving pressure. So you can see how the driving pressure is in this formula a part of calculating your compliance. Mm-hmm. So it's the change in tidal volume, the pressure that you need to change the tidal volume of your lung. is the compliance. What is your PEEP? Your PEEP is.
I was going to say, we hear a lot about PEEP. So I'm wondering, we talk all the time about PEEP when we're talking about ARDS. And in fact, it was part of the Berlin definition's requirement to diagnose the hypoxemia component of the definition, isn't it? So can you explain to us about PEEP? Yeah,
of course. So the PEEP is the end expiratory pressure within a respiratory circuit. Our listeners can probably know a CPAP, so continuous positive airway pressure. And the PEEP is just the end expiratory positive pressure. And in the Berlin criteria, they were asking for a PEEP more than 5. And the PEEP basically is there to keep your alveoli open, to stent, the pressure stents your alveoli open. And so if you have a lower compliance at times, you need more pressure to stent alveoli open. And this is a value that you will set on the ventilator. Or you can, when you back valve your patient, you have a PEEP, you sometimes have a PEEP dial on the ambu bag, for example, that you can dial your PEEP in. I think lastly, we should talk about the PIP, which is the peak inspiratory pressure. And this is a pressure that reflects the pressure in your larger airways or in your endotracheal tube. So it also is part of a compliance, but excuse me, but it does not reflect the pressure in the alveoli, rather the larger airways or also the chest wall. So if you have very obese patients, your peak inspiratory pressure will be higher, and it takes more force and pressure to give a tidal volume to a patient that has a big chest, basically, or a big belly.
Wonderful, thank you. And I just want to point out to the learners that this respiratory care pocket reference card is available to you all. You can go onto the Learning Resource Center and access it there. Alternatively, also part of the opencriticalcare.org website that we pointed out. And thank you to Alana. She put the link in the chat box. So if you want a copy of that pocket card, it will help you not only in defining the parameters, but also help you with mechanical ventilator settings. So here's another key reference. This is a landmark article in the history of ARDS. It's a study that compared tidal volumes of 6 milliliters per kilogram versus 12 milliliters per kilogram. And this really started off the ARDSNet group of research around how to improve outcomes with ARDS. Okay, let's see. Next, we're going to talk about paralysis, and I'm going to ask Dr. Nicholas Suarez to help me with this one, if you don't mind, Dr. Nicholas. You hear sometimes in ARDS that people will use neuromuscular blockers or paralysis, and I'm wondering if you can help us decide if that's something that we want to do for our patients.
Yes, of course. Good morning, Anna. Good morning, everybody, and congratulations for such a great session. So first of all, let's define what this is. So neuromuscular blocking agents paralyze skeletal muscle by blocking the transmission of nerve impulses at the myoneural junction. Okay, so we lose completely our muscle function. Okay, and that includes the one to breathe. So I would like to ask the audience, what do you think about the pros and cons that we have in the use of neuromuscular blocking agents in the treatment of ARDS? Can we give, I don't know, 30 seconds to Anna? Is that okay?
Yes, sounds great. Yeah. I can set a timer for us, no problem. Already we have some answers. Some pros that came in: decrease respiratory work, ventilator synchrony.
Synchrony. Mhm.
I think a con would be ICU acquired weakness and myopathy.
B, yes.
Okay, we're past 30
Okay, yeah.
seconds. I always
Great, so
forget I don't stop the time.
yeah.
We give you more than 30 seconds, so.
So we have really good answers here. So I think we can organize them in pros and cons. There were really good ones. So for example, in pros, we know that when we paralyze all the muscles, we have a decreased work of breathing. So that will help us to improve, as we can see. We can decrease the peak inspiratory pressure. We can decrease the plateau pressures also. And I think that the most important pro of the use in using this treatment is the patient ventilator synchrony, because that way we will take care of all the pressures that are so important in the treatment of a lung that is suffering of this stress syndrome. Okay, and and also if we take care of these pressures, we will decrease the risk of barotrauma as well. That is really important, because as you know, we can see in the patients with COVID today that they have a lot of barotrauma because the lung has a really small compliance, so we can take care of this or at least reduce the risk by using the neuromuscular blockade treatment. And as potential cons, we have, of course, as the audience said, the neuromuscular weakness and the myopathy ICU acquired weakness, which will, of course, prolong the patient day stay and a longer use of mechanical ventilation and myopathy. So yes, this is definitely a con. Also, there is an increased risk of venous thrombosis embolism, and also cardiovascular complications can be increased with the use sometimes of this treatment.
I think that Dr. McDaniel put in a great point that when we have someone on neuromuscular blockade, assuming you have the resources to do so, you should really monitor how deeply blocked they are. I don't know if Dr. Nicholas, you can talk about that a little bit.
Yes, of course. Usually when we admit a patient with a RDS to the ICU, we usually use the BIS system, the Biospectral Index system, and it will monitor the neuron function of the frontal part of the brain. And that way we can see exactly how good of sedation is our patient. And when he's good sedated, we can do the neuromuscular blockade with more security, I think.
Yeah, so we facility will use the BIS monitor, and then we also use a nerve stimulator to measure train of 4, which basically tells you how deeply paralyzed that patient is.
Right, yeah.
Okay, wonderful. Do you, if you wanted to find out more information about neuromuscular blockade, you can go back to this respiratory care card, and you will see that under the adjunct additional resources, you can find some information about paralysis as well. Let me see. Paralysis is right here in red. And so there's some references to some of the key articles and literature that make these recommendations evidence-based. So go back. Wonderful. Okay, and here's some links to some additional articles about neuromuscular blockade. Wonderful. Dr. Vanessa, I'm leaning on you heavily today. I'm wondering if you could help me speak to the audience about fluid management in ARDS. Oh, sorry. Before I go on, Dr. Nicholas, can you speak to paralysis when you have resource constraints? Do you think that you can paralyze patients if you don't have an ICU or don't have a mechanical ventilator?
No, definitely not.
Okay, so that's information that you need to use in a higher resourced area, isn't it?
Yeah. With
Promise
good
I would
monitors.
ask questions, so I want to be consistent. Okay, Dr. Vanessa, are you still with us?
Of course, yep, I'm still here.
Wonderful.
So fluid management is always an interesting topic, not only in ARDS, but we have seen a shift in sepsis in the past couple of years too. And so in ARDS, it also plays a key role. From talking to you about the pathophysiology, you might remember that there's edema and drowning of the alveoli. So in the past, the question has been, when we use fluid, should we be liberal and potentially drown those alveoli more? Or should we be very restrictive with our fluid? And what does fluid therapy do to our other organs, our other end organs, like the kidney, for example? And there is a paper from 2006 that was published in the New England Journal of Medicine that actually did the experiment. And I don't know, Anna, can you pull that paper up, or do we have that somewhere? And thank you. And in this study of over 1,000 patients, the two arms of the study were a very restrictive study with fluid management and a very liberal management with fluids. They looked at the study looked at the mortality in these patients and followed the patients for 28 days. They did not see a change in mortality, so the mortality was similar in both groups. However, what they saw was that when using less fluid, that the patient got off the ventilator 2 days early, which is a long time, and they also left the ICU earlier, which is very big for these patients. And so they concluded that a restrictive therapy has benefits in ARDS. Also, to say is that they looked at end organ damage, and they did not see any differences between these groups. So they didn't have any more acute injury, kidney injury, for example. And so ever since this trial came out now about 15 years ago, we are trying to really reduce the amount of fluid that we're giving to our patients in ARDS, so that we do not flood the lungs with more fluid to add to the worsening pulmonary function, but still be on the safe side with end organ damage. And in this study, Anna, I thought it was interesting to mention too, they looked at the oxygenation index, which is the FiO2 ratio to PA to O2 times the mean airway pressure times 100. And the oxygenation index is a risk, a risk assessment of how high the mortality might be in ARDS. And the oxygenation index uses, again, the ABG, so the blood gas. But you can also use it with just your SpO2. And so then it would be called the oxygen saturation index. And so you would have the ratio of FiO2 to SpO2 times the mean airway pressure times 100. And so in low resource settings, that might be an alternative to using the oxygenation index.
Wonderful. One question, Vanessa, is if it matters whether you're using saline versus lactated ringers. This is a wonderful argument that we talk about with everything from shock to perioperative resuscitation to avoiding renal injury. We always like to talk about saline versus LR or lactated ringers or ringers lactate. So I'm wondering if you have any evidence about improvement in one versus the other.
Yeah, so there have been, I can unfortunately not recall the names of the studies, but there have been a couple of randomized controlled trials out in the recent years comparing lactated ringers and normal saline solutions. And actually, the normal saline solution seems to be worse for the kidney. So in general, nowadays, we barely use actually the normal saline anymore. Because it has been shown to increase acute kidney injury and also hypernatremia. And so most of the resuscitation fluids here in high resource settings is lactated ringers or more of a fully balanced solution like plasma light.
Yeah, plasma light.
That doesn't have the high content of the saline, of the sodium chloride.
I have asked you this before. I've asked others. Can you implement these recommendations in a setting with resource constraints? If you don't have an ICU, you don't have a mechanical ventilator, can you still manage conservative fluid strategies?
I think it's actually resource sparing to use less fluid.
Isn't it?
So I would say, yes, we can.
Absolutely. Excellent point. It's resource sparing. Use less fluid. Perfect. I like the quote, dry lungs are happy lungs. And if you think about the pathophysiology that you described earlier and that you have all of this pulmonary edema and inflammation, that makes sense in my mind that less fluids would be better and improve oxygenation for these patients, just to have less fluids. So Dr. Mull, that was excellent. Thank you so much. I'm going to give you a break and go back to Dr. Nicholas, who's going to talk to us about prone positioning. Dr. Bala mentioned prone positioning earlier in the session, but we want to talk about it just a little bit more to give people practical understanding about when it should be used. So Dr. Nicholas Suarez, if you wouldn't mind, tell us about prone positioning.
Yes, of course. We have a really good trial, which was published in 2013, I think. And it's about the prone positioning in severe acute respiratory distress syndrome. Okay, so there we have like most of the information that we were discussing, and it talks about really important topics about ARDS. So first of all, this trial was published in 2013. It included 466 patients who were followed for 28 days. And severe ARDS was defined as a PF ratio lower than 150 with FiO2 of at least 60%, a PEEP of at least 5 centimeters of water, and a target tidal volume close to 6 milliliters per kilogram. So the primary outcome of this study was the proportion of patients who died from any cause within the 20 days after the inclusion. And they did prone positioning for 16 hours, and then they went to the supine position again. Strict protocols were followed, and the prone positioning strategy was applied every day up to day 28, in which it was used at the clinician's discretion afterwards. So we have a really good conclusion about this trial, which was a decreased 28 and 90-day mortality. So as we can see, this could be a definitely great maneuver, yes, for the patients who are experiencing a severe ARDS situation. So after this, all the prone protocols changed and were included in the treatment of this disease as well.
Wonderful, thank you. I just want to note that the learners, when they're on the LRC or the Learning Resource Center, can click on this prone positioning question and get access to that article. And there's also videos that are embedded in that article. So if you want to see actually how to prone intubated patients, you can do so. So you would use prone positioning in your severe ARDS patients, isn't it?
Yes.
Yeah, and so severe can be
To severe ARDS.
Yeah, and that can be diagnosed with the SpO2 or the PaO2. Can you use prone positioning in non-intubated patients, and does that have any effect on their oxygenation?
Yes, of course. Actually, when people are experiencing respiratory failure and they meet the criteria, even by Berlin criteria, or by the Kigali modification score as well, prone positioning, it has a clear indication because it will help with the oxygenation, and it maybe in some patients, it can really decrease the work of breathing. So yes, it can be done to patients who are not in mechanical ventilation.
Can you just briefly explain why do we think prone positioning works? Not to put you on the spot, I can help, but why do you think it helps oxygenation for these patients?
Yeah, the prone maneuver of the prone positioning will help to to equilibrate or to adequate our ventilation and perfusion zones in the lung. So the parts of the lung that are really affected by gravity and by how the patient is in the bed can just, when they are switched, all of these other parts can be reopened and contribute to the oxygenation. And also, as everything is equilibrated in the lung, then after that, all the pressures can be lowered too, because new alveoli are open, and that will contribute to oxygenation, and all the fluid can be also a little bit shifted, so it will lower the pressure as well. So it helps in that way.
Wonderful. We won't watch the video because we're running short on time, but I will ask Dr. Bala. Thank you, Dr. Nicholas, so much. You're such a good teacher and explain things very clearly. Thank you so much for your...
Thank you, Anna.
Dr. Bala, the last topic is pulmonary vasodilators. Can you help us with this next question? And then we'll go to our small group breakout sessions. This session, we're going to have 5 minutes to spend with panelists so you can ask them your questions. So here is a poll question from Dr. Bala.
Yeah, so I would want the participants to make up their mind whether this particular statement, whether it's true or false. There is ample evidence that inhaled pulmonary vasodilators, such as inhaled nitric oxide and inhaled prostacyclin, improve mortality in ARDS patients. The time starts now.
I love that it's 50-50. That means there's some confusion around the question, so this is a helpful question.
And actually, probably, as Dr. Amal explained, that there is a component of pulmonary hypertension and pulmonary vasoconstriction. So I think going by this class, if they've really keenly watched, I think it's logical to believe that the pulmonary vasodilators do enhance enhance the vascular relaxation and increase the gas exchange. So I think they've listened to the session so very well. That's why there is confusion.
That's why there is confusion. So we're asking if it improves mortality. So when we do research studies, we look at different types of improvements, whether it's mortality improvement, oxygenation, et cetera. So I'm going to go ahead and end this poll, but it's a tight race. I would say, Dr. Bala, 58% say true and 42% say false. So can you please tell us the answer?
This looks like the United States poll, the presidential election, very close.
Don't remind us of our elections, please, sir.
Yeah. So unfortunately, the answer seems to be false because we don't have clear evidence to show that the mortality rates are improved by using inhaled pulmonary vasodilators. So it's an adjunct therapy, but there are no proof.
Yeah, so they improve oxygenation, but we don't have evidence that they improve mortality. So the studies have not revealed that they improve oxygenation, but not mortality. Okay. So what we're going to do next is 5 minutes with your panelists. So we're going to break the learners up into 3 different breakout rooms. And in each room, you'll have a couple of panelists. And the 5 minutes we'll spend discussing how you can change your practice. So tell the panelists what you're going to adopt into your practice to change. And what interventions can be employed even when an ICU is not available. So if you're in a practice setting where your resources are constrained, there are still things from this lecture that you can take away to improve the outcomes of your patients, whether it's oxygenation or mortality. And then if we have time, we can do some questions and answers. So with that, I'll ask the Project ECHO team to help us go into these breakout sessions. So thank you. And apologies to some because the breakout rooms accidentally kicked some people off. So apologies to anyone who was unable to attend in the breakout sessions. I want to again thank first all of our learners for joining us and trying to improve the care of your patients with ARDS. And then secondly, I would just every time we have a panel of this caliber from all over the world, I just feel humbled and honored to know all of these panelists. Very, very good session with our experts. So thank you so much. And finally, last but not least, thank you to Assist International and Project ECHO, specifically Alana Shangor, who makes all of this happen seamlessly. So thanks to you all, and we will see you next month on March 22nd. We'll be talking about high flow nasal cannula and non-invasive positive pressure ventilation. So thanks to you all.
Thank you.
Thank you so much.
Thank you.